So welcome everyone to eHealth 2023. It's so great to see everybody today. Good morning, Toronto. Good morning, Canada. People who are joining us from the live streaming from the conference app. Good morning wherever you are. Good afternoon or good day. It's so great to see everybody at the Beanfield Centre, Canada's greenest conference centres. And we are live and in person after like 3 years of absence. So this is going to be a great couple of days. My name is Sheila Maloney. I'm Executive Vice President at Canada Health Infoway, and thrilled to be one of your co-host MCs, along with my partners in crime, Cassie and Steve, who I will let introduce themselves.
Morning, everybody. I'm Steve O'Reilly. I'm the Executive Director of Federal Relations at the Canadian Institute for Health Information. Really thrilled to be back in person and have so many of us joining at the event, especially during such a crazy busy time. Our mission at this event is to learn, network, and connect health professionals sharing ideas, expertise, successes, and challenges across Canada and beyond.
And I'm Cassie Fraser, President and Board Chair for Digital Health Canada. We are your host MCs, and we welcome you to eHealth 2023 Conference and Trade Show, Canada's largest digital health event. And I just want to add that I've had the pleasure of being your virtual MC for the past 2 years, and actually getting to see you is pretty cool. A little bit terrifying, but it's also very cool. And it's better than seeing my neighbor collecting the recycling bins. I have to say you look amazing, and very good call on switching out of the pajama bottom pants for this one. So I'd like to begin with the land acknowledgement. We gratefully acknowledge that we are on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit and the Williams Treaty, and signed with many of the Mississaugas and Chippewa bands. Acknowledging the land is an Indigenous practice that has been happening for thousands of years. It respects the legal and spiritual relationship that Indigenous peoples have with their territories. We recognize the many injustices experienced by the Indigenous peoples of what we now call Canada, and that continues to affect their health and well-being. And we respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We invite all attendees to reflect on the territories from where you live as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. We respect the continued connections with the past, the present, the future, and in our ongoing relationships with Indigenous and other peoples in our communities. I'd now ask you to please rise for O Canada. Thank you. It gives us great pleasure to share this video welcome from the Honourable Sylvia Jones, Deputy Premier and Minister of Health.
Hello, everyone. I'm Sylvia Jones, Ontario's Deputy Premier and Minister of Health. On behalf of Premier Ford and our government, I would like to extend a warm welcome to all of you taking part in the eHealth 2023 conference. We appreciate the important work you do and your significant contributions to our healthcare system. And thank you to Canada Health Infoway, the Canadian Institute for Health Information, and Digital Health Canada for hosting this conference, and your ongoing efforts to advance digital health and improve patient care. Ontario is a hub of innovation and home to a thriving research and technology ecosystem. I've had the privilege to travel across Ontario and see many examples of state-of-the-art and world-class healthcare taking place in local communities. It's great to see the ongoing collaboration, partnerships, and creativity taking place across the broader health sector. And our government is working hard to make it easier and more convenient for Ontarians to connect to the care they need closer to home. A key part of the province's healthcare plan is to continue supporting and making advancements in our digital and data systems to drive improvements in patient care and help build a more connected healthcare system. We're making important progress here in Ontario. More than 266,000 frontline providers can access provincially held patient health records, leading to more integrated care and better decision-making. Nearly all Ontarians who receive health services now benefit from digital records containing information that can be accessed by authorized healthcare providers. Digital and data tools are playing a key role in enabling more connected care through Ontario Health Teams, which are a model of integrated care where health and community care providers work as a collaborative team to better coordinate patient care and share resources. Ontario is supporting important developments in digital health in other ways, including continuing to modernize providers' point-of-care systems, providing clear guidance to digital health vendors and healthcare providers through the Digital Health Information Exchange Program, supporting more standardization and seamless access to patient information, investing in clinical information sharing between hospitals and the long-term care sector to streamline readmissions and share information with families, and investing in systems to support electronic consults, referrals, and centralized wait time management. These kinds of advancements and innovations are ultimately contributing to better patient experiences for Ontarians. And the province will continue working with our partners to take full advantage of the potential digital health has to offer as we keep building a stronger, more connected, and convenient healthcare system. Thank you again to everyone here for your contribution to healthcare in Ontario. I hope you have a successful and productive conference. Stay well.
So thanks, everybody. We'd like to acknowledge our host organizations, Canada Health Infoway, the Canadian Institute for Health Information, and of course, Digital Health Canada. And we have a number of active committees that support this event: the Host Steering Committee, an Abstract Review Committee, a Program Plenary Committee, and a Logistics Committee. And our thanks for all of you for your able and committed stewardship in making this program a reality this year. As in the past, the eHealth Conference is largely due to the incredible commitment of many volunteers and sponsors. Once again, we have a program that is even bigger, better, deeper, and more accessible than ever. So we want to acknowledge our various level sponsors. At the Diamond level, it's Accenture, Novartis, and Salesforce. Our gold sponsor, AWS. Silver sponsors, Aconox, AVI SPL, Baxter, CrowdStrike Zscaler, eHealth Centre of Excellence, Ontario MD, Orion Health, Smile Digital Health, and Well Health. And our bronze sponsors, Angus Connect, Calian, CDW, Fortinet, Microsoft, Netscope, OKTA, NTT Data, ServiceNow, Teladoc Health, and TELUS Health. So thank you to all. We're also pleased to be a patients-included conference and to have patient partners as key health community members and important e-health contributors. Patients and caregivers have had direct involvement and influence in the planning of e-health as members of the program committee, also as abstract reviewers and presenters. They participate in selecting the patient scholarship recipients, organize patient partner meetups, and contributed valuable insights to the discussions at eHealth. We acknowledge their experience and commitment of these patients and caregivers in helping to shape the content and perspectives provided by eHealth. Partners involved this year were, on the Patient Scholarship Committee, we had Flavie Laliberté from Quebec, Louise Bird and Brenda Andreas from Saskatchewan, and on the Abstract Committee, we had Anne O'Riordan, an advisor from Kingston, and on our Program Plenary Committee member was Sonia Kumar-Seguin, down from Hamilton. So let's talk about one of the pillars of our conference, the conference program itself. This year, we received 255 abstract submissions and confirmed 175 concurrent sessions, consisting of e-posters, panels, and both oral and rapid-fire presentations. Each of the abstracts was blind reviewed by 3 members of our very talented 20-member volunteer abstract review committee. And the program committee consisted of another 15 volunteers who successfully completed their challenging task in record time this year. We had a very compressed schedule. And thank you to both the abstract and program committees for your time and your diligence. We have 275 speakers and 30 moderators. We hope you've had a chance to look at the conference app, browse through the conference program, and select the most interesting sessions. Next 2 days are packed with fantastic panels, rapid fires, showcases, symposia, and plenaries lined up for you. That's it.
Okay, so little housekeeping details and some programming changes for program 2023. The eHealth Conference app, I hope you've all downloaded it, WOVA. It's sponsored by the eHealth Center of Excellence, so thank you for that. Everything you need, the agenda, it's all on there, so please review that and take some time. It's going to be very helpful for you. The plenary area, so that's where we are now. This is, if you're ever lost, come back here. So the opening ceremony, the opening keynote, our host plenary session this afternoon. Our social night is here tonight, and tomorrow's plenary and tomorrow's closing keynote and closing ceremony, so all here. You can connect to 95 leading health organizations, vendors in our exhibit hall right next door. We've got 17 startups in our startup booth, sort of across the way, and 315 plus exhibitors who are on hand to answer any questions you have. So the exhibit hall is a networking galaxy. Sessions take place in the numbered pods that are around the exhibit area. You will need headsets, and the headsets, you can get them out in the main hall. You ensure that you pick up the audio headset across the registration. You'll be able to move freely between the open concept conference sections. Each pod is numbered, and the headsets will be connected to transmitters where you will tune in to the pod channel to listen to live speaker presentations. If you need to go up to take the escalator upstairs to the main floor, we have 2 spaces available to you. The chill space, which is, thank you to Salesforce for sponsoring that. Nice quiet space where you can sit and unwind. Or for those of you who are of the opposite ilk, the work space. And that's a fully powered, quiet desk area where you can catch up on emails. There is an information kiosk. There's a Baxter sign just across near the startup zone. And any questions you might have, if you're not listening to me right now and you think, oh, what did she say about that? You can go to the information session or ask any of the volunteers. Volunteers are in bright orange T-shirts. Thank you to Equinox for sponsoring them. And they'll be able to answer any questions you have. One of the program changes that's different this year is we will actually be announcing our award winners throughout the conference and not having a gala as we've done in the past. And so we'll acknowledge the achievements and awards throughout the plenary sessions. And in addition, the conference breaks and lunches will be in the exhibit trade show floor. So I'm sure most of you are excited to celebrate being back in person again and looking forward to the evening's Blues and Country Social Night, sponsored by Accenture. So wear your jeans and your cowboy boots and your hats or anything and come and again, plenary session here tonight at the Blues Night. So let's get this party started. That's it for the opening sessions, and we are going to have 2 days of innovation and networking and education, and really looking forward to it. And we've got a great start to our conference. We've got the very, very privileged and excited to introduce the Federal Health Minister, Minister Jean-Yves Duclos, to the conference to provide an exciting announcement for us and make some opening remarks. The Minister Duclos will be joined on stage by Flavie Laliberté, who is one of our patient advisors and a new mother, and Michael Green, who's the President and CEO of Canada Health Infoway. And so please help me and join me in welcoming them to the stage. Thank you.
Well, thanks very much, Sheila, for a great introduction, and welcome everybody here today. And as Sheila said, I'm Michael Green, President CEO of Canada Health Infoway, and I'm very pleased and honoured to be joined by two guests to open the conference today. So with me on the panel, I have Canada's Minister of Health, Jean-Yves Duclos, who is a great proponent of digital health and modernising the system, and also patient partner Flavie La Liberté.
Close,
and
yeah.
Flavie joined us at our partnership conference,
Yes.
as did the Minister in the fall. So it would be great to kind of carry on with that discussion. And of course, our focus for this conference, the first face-to-face conference we've had since 2019, which I believe was in this venue as well at that particular time. And it's great to get back together. Obviously, very good to see enthusiastic attendance of the event. And during the pandemic, as we all know, especially if you're a health provider or if you're a patient, things had to change a lot, and virtual care came in during the pandemic. And I think we all saw the kind of efficiencies and benefits that digital health can bring, but also we're mindful it needs to be used sensibly and appropriately. And so today, as we mentioned, we have an exciting announcement to make. But before we get into that, I'd like to have a bit of a discussion with the Minister and also with Flavie. And first of all, Flavie, I'll start with you. So after suffering, I know, from a severe gymnastic accident and suffering chronic pain since, I think, 2009, you've made it your mission to advocate for patients to have access to all of their medical data and fast access to quality care. So in your experience as a patient with chronic conditions and an advocate for many others, could you enlighten us on some of the key challenges that patients are facing in our healthcare system today?
Absolutely. Thank you. So healing is a team sport. You've got the patient, you've got the caregivers, you've got the physicians, the pharmacists, the physio, and data is the ball. And right now, it is the patient or the caregiver's duty to grab that information, print it off, photocopy it, put it in a binder, and bring it physically to every new provider that you're going to see. And we talk a lot about clinician workload and reducing the administrative tasks that they have to do over and over again, but I also want to bring out the patient workload. In an ideal world, the patient workload should be to heal, to rest, and to just be carried from places to places for treatment and get back on their feet. But right now, the workload is very administrative heavy. It's spending time going to appointment and taking photocopying, paying to have access to those things, faxing things. If I see another fax machine, I'm throwing it in the river. So right now, there's a lot of burden on the patient to do that themselves. And when we talk about patient frustration, it's not the correct term. Frustration is when you don't get the right kind of burger in your order. The patient is anxious, the patient is in pain, the patient is overwhelmed. So in most cases, they barely have the capacity to do that for themselves or to advocate for themselves. So reducing that burden for the patient so they can focus on healing should be a priority.
Great insights, thank you. And so now, Mr. Duclos, so we've just heard from Flavie, about some of the issues that patients are facing in healthcare today. What is the Government of Canada doing to address some of these issues?
Bien, tout d'abord, merci beaucoup, Michael, et merci à tout le monde de nous faire un peu de place dans votre programme très chargé. C'est une grande chance que j'ai d'être avec vous aujourd'hui. I would like to thank Digital Health Canada. I would like to thank, obviously, Canada Infoway and your leadership and partnership, Michael in particular, Kai, mais aussi vous, Flavie, jeune maman d'un petit garçon, Marcel, de 4 mois, qui est quelque part, dont le papa Brad prend soin présentement, et ce qui nous permet de vous entendre, Flavie, which allows us also to speak in a very grounded manner of the critical and urgent nature of the work that you do. We've gone through COVID-19, which has damaged, obviously, in all sorts of ways, our country, workers, and patients in the healthcare system. So although we did really well compared to most other comparable countries from an economic, a health, a social, and cohesion perspective, we obviously need to repair our system, and we need to prepare the healthcare system, for the challenges of the future. Our population is obviously aging quickly. Our population of workers is also aging quickly. We're faced with increasing incidence of chronic diseases. We also know that future pandemics will come. Now, the good news is that medical technology is also improving. We've seen the tremendous impact that scientists and researchers have made on protecting the health and safety of Canadians in the last 3 years. We also know that digital technology and data are there to support workers and patients. That's in this context that the Prime Minister, you might remember, announced just a few months ago on February the 7th, a $200 billion plan, in addition to the existing dollars, to support workers and patients over the next decade. Now, that plan has briefly 4 pieces to it, which are all connected and, in fact, important in the context of this conference. The first is to acknowledge the pivotal central role of primary care family medicine in Canada. The accessibility to healthcare is the cornerstone of a properly functioning healthcare system. The second thing is mental health, investing in mental health, especially for younger Canadians who, and many others, have struggled through COVID-19 and keep struggling in the light and in the midst of all the challenges that humanity and the planet are living through. The other point is workers, how to retain them. That means, therefore, how to better support them, how to recruit more of them by, obviously, training adapted to their conditions, including career laddering, how we can recognize better and faster the credentials of those trained in other places in Canada and internationally. And finally, how we plan better for their future and invest, therefore, better in the future of the health workforce. And that will come in part through the Center of Excellence of the future of the health workforce, which is going to be set up in the next few months. Now, that is, and I'll end with that, in the context of what you've said, Michael, modernizing our healthcare system, and that involves a better access to, better use of, and better sharing of the key data that are protective of the health and safety of patients, but also of workers.
Excellent. And leading on from that, Flavie, you've talked a bit about the frustrations that patients face when you don't have connected data. How about your experiences when you do have that data connection?
Yes. So when you suffer from chronic pain, every action in your day takes a lot of effort and energy. So if we can reduce the action that needs to be taken and going places and showing up in person, emphasis on virtual care, it reduces the strain on the patient. The ideal goal would be to empower the patients to have their diagnosis, to be able to communicate with their doctors, with their physicians, with their whole team, and to manage their condition themselves, and to empower them to take care of their own health, track their symptoms. And it's so primordial because we want to reduce that strain on the system, because the alternative is going to DR. And as we know, the average time of wait is 21 hours nationwide. Yeah. So we want to, because we don't want to be a burden, and we want to be able to make decisions for ourselves. And that's the most important part.
So it's the empowerment that is a big thing, it seems to me, and the convenience as well. Yeah. And Minister, can you share with us, why you believe modernizing healthcare system with standardized health data and digital tools is such a priority?
Well, let me do that in the double C, the context and the catching up. Premièrement, le contexte. Le Canada est un pays immense, est un pays avec une densité de population faible, densité de services aussi assez limitée, un pays où les soins de santé sont décentralisés, ce qui est à la fois une force et un enjeu. Une force parce que la décentralisation permet de réagir plus rapidement et plus correctement aux enjeux locaux, mais un enjeu parce que ça nous amène à travailler davantage en silo. Un pays où la mobilité des travailleurs et des patients, c'est aussi significatif. Les gens voyagent, les gens déménagent. Et dans ce contexte, donc, le défi, c'est de rassembler les forces en permettant un travail décentralisé. But the catching up is also very important. We want to be honest, Canadians. We know that we are in the health field behind other fields like banking, where it is now absolutely normal to have access to confidential, secure banking information, which is shared in appropriate manners. We're also behind other countries, including the United States, when it comes to sharing and accessing data. Behind Denmark, a much smaller country, obviously, but also behind Australia and other places. We know that a minority of patients currently have access to comprehensive medical records. A minority of physicians, for example, can share data outside of their practice, and that is obviously a challenge when we speak about the need for paramedics, for instance, to have access to essential and quick information that can save lives. When you think of nurses not having access to the drug information for the people that they care, when we think about lab results not being accessible speedily and appropriately to physicians and pharmacists, and avoiding the use of faxes. And when we speak about things that we need to do more and better of, and which is home care, for instance. Home care is absolutely essential, and absolutely essential is the use of data and the proper use of data to support home care. And finally, pandemics again. I'll end with that because the context and the catching up in terms of pandemics is key. Now, we want to have a better public health system in Canada, and that requires better use and better access to data.
Great. And picking up on that data aspect, focusing on implementing the standards that are required for supporting data access, exchange of electronic health information and so on. Canada Health Infoway has worked hand in hand with the Government of Canada and the provinces and territories over the past few years to drive progress on this front. Today, we're also really excited to announce the publication of the Shared Pan-Canadian Interoperability Roadmap. And I think all of you may have had one of these QR codes on your chair, and if you scan it, you can get immediate access to that roadmap. And so I'd like to ask Minister Duclos, would you do the honors of shedding some light on how we got there today and what the interoperability roadmap means for Canadians?
Thank you, Michael. And it's important to share the challenges that we are facing. That can be a bit somber. Sometimes it's also important to mention the progress that we are making. And one such progress, not in your domain, perhaps, is at the political level, between provinces, territories, Indigenous peoples, and the federal government. We have agreed together, provinces, territories, and federal governments, just a few weeks ago, we have agreed to support the Pan-Canadian Interoperability Roadmap, la feuille de route pan-canadienne en matière d'interopérabilité, because we know it's key to advancing our work and your work in particular. It has six objectives. The first one is to prevent data blocking in order to support competitiveness, competition, and innovation. The second objective is to enable patient access to safe, reliable, and strong health records, while supporting, as I mentioned, the privacy and the safety of those records. The third is to improve provider access. I mentioned just earlier, high provider access and provider sharing of data can save lives in some circumstances. The fourth is to support virtual care. You mentioned that, Michael, earlier. Virtual care, the impact it can have on e-referral, e-consultation, the impact it can have on the ability for communities, especially in remote and rural and northern areas, the ability for those communities to have access to the same quality of care, despite the fact that they can live farther and can face all sorts of barriers in accessing health care in traditional manners. The fifth is to support learning in our medical world. Now, learning when it comes to the efficiency and safety of drugs, of treatments, of vaccines, certainly, but also learning in terms of how we can make our medical working environments more conducive to teamwork. Teamwork is absolutely essential for primary care and all sorts of other forms of healthcare. But teamwork can be properly supported only if there is sharing of data, so there can be sharing of responsibilities as well. So, and things like remuneration and combination of work settings. And finally, as I've mentioned quickly earlier, to provide a more appropriate setting for the future public health crisis that we will be facing. Again, we need to support interoperability as one of the many tools that will be essential when that comes.
Excellent. Thank you very much. That's a great explanation. And I noticed there's a flashing red light in front of us. So I think we have to come to kind of concluding our remarks. So, again, I'd like to thank you both for joining me on the stage here. And, I think in particular, when we look at countries that have been successful in implementing this technology, one of the key aspects is to have the leadership from the top, from the health minister, from the prime minister, from the premiers and the ministers across the country. And I really do think we have that commitment. And certainly, Mr. Duclos, you show your own knowledge is superb in this particular area, and enjoy working with you in the future. And again, from a patient perspective, this is what it's all about, really, empowering patients and truly putting patients at the center of the system, which is something we've all been striving to do. I don't think we've achieved it yet, and we've still got a lot of work to go. So I'd like to thank everybody, and if you have any closing comments that you'd like to make, be very happy to have a few closing remarks. Flavie?
Sure. I mean, data interoperability, I'm not sure most patients understand what it means, but they definitely feel when it doesn't work.
Sure.
It's the basis on which e-referrals, e-consults, sharing medical records will be established Canada-wide, and they can't wait for that to happen. So, excited.
Bien, très rapidement, j'aimerais tout d'abord vous remercier, Flavie, pour votre propre leadership. C'est quand on voit des gens comme vous, avec à la fois le vécu réel, mais aussi l'expertise et le leadership, c'est là qu'on sait et qu'on sent que les efforts que l'on fait à des niveaux plus agrégés, quand on se rencontre les ministres de la Santé, c'est là qu'on voit que ces efforts ont un sens réel. Thank you also, Michael, for your own leadership. Canada Infoway has been a strong partner and a leader in a world in which we need you and your team. But most importantly, perhaps, and equally importantly, certainly, thank you to all of you. We all have a role to play, different roles, but the same responsibility, which is to look after thousands and millions of people whose lives, health and safety in many cases depend on your collaboration, on your own leadership efforts. So we know we have benefited enormously from that leadership and that collaboration in the last few years, certainly, and we know that we can count on it for the future of Canada. Thank you.
Great. Lovely. Okay.
Oh, thank you so much.
Thanks very much.
Oh.
Thank you.
Oh, thank you so much.
Okay.
I do the same thing I told you that I never would.
Well, thanks very much for that. So moving quickly on to the next session, I'm going to be, in a minute, I'm going to be introducing Kaveh Safavi, who will give us a really interesting discussion on the role of digital and technology in our future workforce, which is always a key element. And as we heard this morning, we really do want to put the patient in the center of the picture. But I think obviously the process of doing that means implementing smarter technology to allow our providers to do a much more effective and efficient job. Health human resources has been the topic of a number of conferences. Recently, I've been to a few in Canada, also in the US and in Europe, and there seems to be a common thread. It doesn't matter if you've got a public system, if you have a system like Canada, or if you have a system like the United States or the ones in Europe. The common theme seems to be that there is a surplus of demand and a deficit of supply, and we're reaching a wall in terms of healthcare providers. People are retiring, new people are taking too long to bring on board, and so we need to look towards technology and other ways of doing this. So, as I mentioned, I'm very pleased to introduce Dr. Kaveh Safavi. He is basically going to be talking about the role of digital and technology in the future workforce and reinvention to build a future-ready healthcare workforce. So Dr. Safavi is from Accenture, who are the sponsor of the Keynote as well. He's a senior managing director at Accenture, where he's responsible for leading and developing and driving a growth strategy that differentiates Accenture's offerings for providers, health insurers, and public and private health systems across the globe. And so with that, I'm going to introduce the speaker, and then I'll come back and we'll have a Q&A after the talk. And I think there should be the opportunity for you also to ask questions, either using the mics or posting them on the app, and I'll have an iPad up here to help with that. So, thank you.
Michael. I was hoping I was going to get Dua Lipa for walk-up music. I guess I didn't ask you guys to do that for me. Thank you. Good morning. Nice to be here with all of you, and hopefully we'll get this meeting off to an interesting perspective. My name is Kaveh Safavi. I have spent the last, say, post-COVID year in about 10 countries, and every conversation that I have had with leadership, healthcare leadership, the conversation has eventually shifted to the biggest concern they have, which is the fact that they don't have enough people to do the work. And I want to talk about that, because that has been described as a workforce problem, except when you ask the question, will there ever be enough people to do the work? And then you realize it's not a workforce problem, it's a work problem. And the only way we're going to solve that problem is to take work that is done by people and rethink how we do it by taking jobs, making them tasks, and then asking the question, what's the best way to do this task? Is it a person? Is it a technology? What kind of a person? And so what I want to talk today to you about is what I call the future of work, of which workforce is a component of that. But why do we worry about this? I looked some numbers up before I came here. The last published numbers I saw on median waiting time for healthcare services in Canada, all provinces, all services, is over 6 months. That's a 1.5 month increase since the pandemic. You started tracking it about 30 years ago when the wait time was less than 2 months. If you are in the UK right now in the NHS and you want a service, the average wait time for an elective procedure is between 18 and 24 months. If you're in Ireland, it's over 2 years. It was 4 years coming out of the pandemic. In the United States, we are starting to see people with what we'll call good health insurance in the Pacific Northwest waiting 6 weeks to see a primary care doctor. It's 6 weeks or an emergency room. We've never had that before in the United States. All of this is fundamentally anchored in a basic problem, which is the mismatch between the supply of services of people to do the work and the demand for services. Now, I have some US numbers here, but I actually found the Canadian numbers, and it's really important to try to think about this. The demand can best be articulated by things like age. So if you looked at the next 25 years in Canada, the number of people who will age past 65 will grow by 25%. That population consumes 3 to 5 times as much health care as people under that age. The number of working people who support those people will go down by 32% in the same time period. We have a supply and demand mismatch problem that will never be solved through employment. This, by the way, we know is a global issue that's underpinning the global inflation rate, the lack of workers relative to the amount of demand. But in healthcare, it's much worse, because every single time someone retires out of the workforce in healthcare, they're a non-linear increase on the demand side of the equation. And the way we think about work has largely been by adding people. Healthcare is a completely human-dependent sector of our society. Some interesting research that came out of the United States was published in 2019, looked at the relative contributions of labor, capital, and technology to economic growth. So think of that as healthcare growth versus overall economic expansion. This is US numbers, and I want to talk about them because there's an illustrative lesson in here. But in the 15 years of this study, the overall US economy grew. 25% of the growth came from labor, and the rest came from either capital or technology. The healthcare sector in the same time period, 99% labor-based growth. So essentially, we'll call it 100% labor. But we did add technology in that time period. As you know, we probably have the highest level of penetration of things like electronic health record in hospitals. The effect of technology on healthcare in the United States was to reduce human productivity by 13%. It's the only sector of society where technology reduced human productivity. Why did it reduce human productivity? Because people need to type. Why do they need to type? Because it's the only way to get structured data concepts that are machine readable for things like decision support. The business case for technology in healthcare was built around the need for technology to make healthcare better. It started with To Err is Human in 1998, where we were losing the effectively 1 jumbo jet worth of patients every day for errors in the hospital. We have evidence that the technology has in fact made healthcare safer in hospitals, less rates of deaths for people who shouldn't die, fewer errors, but it came at a price. And it was fine when we had enough people to do the work. But now we don't have enough people to do the work. So the business case that we were built around, which is technology to make healthcare better, is not the business case that we need going forward. We need to ask a different question, or we're going to have catastrophic access problems. And that's what I want to talk about. Because every other sector has figured out how you can use technology to expand human capacity. And we have to ask a slightly different question. We have to take a job that's done by a person, and we have to break it into its tasks. And then we have to ask the question, where do the tasks get done? Now, historically, that's used through the lens of automation. This is some research from Brookings. This is about 3 years old. And it asks the question, how much of what we do in healthcare is automatable? And the answer is somewhere in the medium range. It's actually, so they have industries that are highly automatable, medium, and lower. Healthcare sits in the middle range, which is between 30 and 70%. It's actually in the 30 to 40% range. This is all forms of automation. Several things to learn about this. Number one, we will still be a predominantly human profession and sector. We can't, in fact, people have looked at the probability of complete replacement of a healthcare worker job. For example, a doctor, less than 1%, call it 0. These are not jobs that can be replaced by technology, but each job has a task that can be replaced by technology. And that's where we want to focus on. What are the tasks that can be replaced? The good news is this was produced before the era of generative AI. And in fact, we have some research that will be published. This is research that's before generative AI has reached people's consciousness. This is Canadian research. You'll see it shortly. I just wanted to excerpt this for you. This is Canadian healthcare providers' perspective on tasks that they do for which technology can automate. And you can see the categories here: registration, inventory management, billing, scheduling. Not surprising, all of these are in the 75 to 100% range. Since this time, the emergence of generative artificial intelligence has occurred. And generative artificial intelligence is profound because of its effect on language and the ability for it to take over language skills. We recently published work looking at the ability for generative AI and language skills to affect work in every sector of the economy. This is actually the healthcare sectors. This is the global numbers, and the way to read this is what's in purple are things that are done by people, language-based, that technology can fully replace. That turquoise in the middle represents tasks that are done by people that can be augmented, but not fully replaced. So the impact of generative AI on our work is in the 30 to 40% range, but somewhere around a quarter of what we do can be fully replaced by generative AI. That is a different statement than eliminating unneeded services. These are services that things that need to be done, but we can do them differently. So for example, if you think about the two tasks that are probably the most time-consuming, both of which are amenable technology, the first is the ability to create a narrative to describe the work that's being done. The ability to listen to a conversation between a doctor and a patient and generate a note so the doctor doesn't have to take the time to intentionally dictate a note. The ability to watch a nurse take care of a patient and to auto-generate documentation. All of those things are within the realm of reality. The other side of the equation is the typing side of the equation. Why do we make people type? We make them type to create structured data concepts that we can then make machine readable, that we can do decision support and analytics and other sorts of things. Generative AI is fantastic at looking at a narrative and creating structured concepts, taking away the need for human beings to do all of that work. If you look at what a nurse does, for example, on a floor, about half of the time that they spend is doing two things. They look at numbers on a machine and they write them down, or they describe what's going on with that patient or what happened to that patient over the period since they were last seen. That job is completely amenable to technology. Now, why is this number important? The workforce shortage in Canada is if you look at the numbers, you have about 500,000, little less than 500,000 nurses in the workforce. In the next 10 years, the demand is going to grow by about 117,000. That's going to create a net shortage of 20% if we don't solve the problem. The US is about 15% in the same time period if we don't solve the problem. The good news is that's about the percentage of work that we can free up just through technology without solving any other problem. So at least we have a proximate relationship between the problem and an alternative to the problem. Because if we don't, then we're going to face the more serious problem, which is waiting times. In the United States, if you actually look, we are suffering tremendously under the consequences of a nursing shortage. And here's how it's being felt. The first thing that's happening is the cost per care for patients per admission, for example, has grown by around 15%. The next thing that's happening is they don't have the capacity to take patients in. So for a hospital, they're suffering both an expense problem and a revenue problem. It's the reason why in 2022, the Cleveland Clinic reported its first ever operating loss in its history, totally driven by the fact that not enough labor meant the cost of labor went up, coupled by the reduction in revenue. And that scenario is playing itself out pretty much in every geography. However it's financed, it's being played out the same way. But now we have a line of sight. But it's not so simple. You can't just take the technology and walk it in, plug it in, and expect that you're going to be able to gain the benefits. In fact, if you look at what happens when you introduce technology into a workforce, you take tasks away from people, but in order to take those tasks away and gain any benefit, you actually have to take the remaining work and redistribute it. So if I were to show up with a technology that would take about 20% of what a nurse does and do it for that nurse, I have an 80% nurse. And if I stop there, I just made the system less efficient. The only way to get the system more efficient is to take that 80%, collect them all up, and then redistribute them as 100%. But that changes the job of a nurse. It takes the harder task and it concentrates them. And when you take that process and you concentrate those tasks, what you realize is the workforce that I need is different than the one that I have. Because I don't need all of those skills available all the time. So we actually looked at this, and what we concluded was that when we take the way we do work today, which is a lot of people doing a little of everything, and we project it forward into a world where technology takes over a certain percentage of the tasks, we actually have a different kind of workforce. We have a workforce comprised of what we call fixed and adaptive workers. The fixed workers do a little bit of everything, and the adaptive workers do highly specialized things that come and go based on either volume or expertise. And what our team here did was last year is we actually looked at 5 roles in acute care hospitals. When you think about this is real analysis based on work and where we had line of sight to technology about what work looks like when you go from today to tomorrow. So if you look at that top line and you think about 10 registered nurses today doing the work, the tomorrow is the same work being done by a coordinated effort of 4 bots and 6 humans. But those 6 humans aren't all doing the same thing. 4 of them are doing a little bit of a lot of things, and 2 of them are doing things that only are done at certain times. And work is getting done by coordinating all of those together. It's not a direct replacement. It's a new job that requires the collaboration of fixed and adaptive and technology working all together. If you look, though, at, for example, the 4th line down, which is the second from the bottom, that's a physician role, a hospitalist role. And if I have 10 physicians doing the same thing today, tomorrow I still have 6 doing the same thing. But there are also 3 bots and 1 doctor who is an adaptive workforce who comes and goes either based on volume or specific expertise. So it's not a one-size-fits-all. Now, we're already beginning to see this play itself out in acute care nursing in the United States. If any of you have been following the category called virtual nursing, some of you might have, it's actually the problem with that term is it's been around for a while and it represents a heterogeneous group of technologies. But the one that's the most interesting and the newest, I'll use that to illustrate it, starts with the recognition that 50% of what a nurse does is write things down. And it asks the question, why does the nurse in the room have to write things down? And what it essentially does is it lets the nurse in the room go about their day, having a conversation with the patient and doing all the physical tasking that they do. And because the data can be collected directly from the technology and through voice and video, in a remote location, a different nurse is writing things down and generating the record. That's a human-based model. But it gives them access to a bigger labor pool. Where they're experimenting with this at the Mayo Clinic right now, they're using nurses who would have otherwise been out of the workforce because of physical leave. Let's say they injured their back. Instead of being off and having you one down, that nurse can now do all the documentation tasks, freeing up the nurse at the bedside to continue to do their work. And we know generative AI at some point will replace a significant percentage of that work. And this allows us to let the nurses at the bedside continue to have the conversation, continue to do all the physical tasking, but the documentation is getting created passively. That's an example of the journey that we go through when we start with today and we think about it all the way to tomorrow. So right now you have an adaptive workforce, which is documenting nurses and caring nurses, and tomorrow you're going to have all caring nurses, documentation moved over to the bot. This isn't just the clinical side of the house. That workforce shortage is actually across all sectors. So we've looked at non-clinical. This is finance, because finance is one which is quite amenable. And you can see, for example, accountants versus analysts, the role of technology and the role of adaptive workforces. Now, this is a journey. This is not something simple. You don't just drop this in. There's no blueprint for this. There are a series of unknowns here that we're going to have to learn our way through. One of the unknowns, for example, is when I take easy tasks away from people, I leave them with hard tasks. And it turns out we hate that. This work has been done with doctors who complain bitterly about administrative tasks, even before technology. And models were done where we gave the easy work to non-doctors because they said, that's beneath me. And guess what? They complained even more. Why did they complain? We're seeing this right now with telemedicine. Because the brain can't work at peak capacity continuously. It's called cognitive overload. All that complaining actually represented brain rest. We're seeing this right now in practices that are using virtual visits to take the doctor's load and basically say we're going to preserve all the inpatient for the, let's call it complicated patients, and we're going to move the easy patients to a doctor who's in a remote location. The doctors who are doing the in-person hate it because they have no time to rest. So nobody has any idea how much work will change based on this. And I would argue that that means we probably won't get the full 30 or 40% because it's an asymptote. But if I can get half of that, I'm beginning to get to closing again. So if 40% potential and I can get half, that's 20. Turns out that's your nursing problem right there. All I need is half. So that's the kind of situation that we're really working with. But that requires us to rethink work. And the hardest part of this is not the tech, it's the work part. We're increasingly discovering with people who are going first is, sure, tech is hard and it doesn't exist and I have to experiment with it and I have a whole bunch of conditioned precedents on the technology side just to put the tech in. But when I'm done, I still have to remodel work or I gain no benefit. Here's the other problem. You're not moving a whole job, you're just moving tasks. And when humans and machines work together collaboratively, a whole new set of skills needs to be acquired by the human being. These are called hybrid or middle skills. This has been work that has started in the human-computer labs all over the world, and we're now beginning to understand that in industries where we see humans and machines working together. So in manufacturing and logistics, manufacturing actually we started, there's a term called a cobot. It's a worker, robot, coworker. The work gets done by humans and machines working together collaboratively. That requires a set of skills that we don't have and have to acquire. I'll just illustrate two of them for you right now that are on this page, but this is actually work that, there's a book called Human Plus Machine that our Chief Technology Officer, Paul Doherty, wrote that talks at least in one of the chapters about it. It's really interesting. Intelligent interrogation, and you're beginning to see this. If anyone has played with ChatGPT, consumer grade, you will recognize the fact that the answer is dependent on the way you ask the question. The prompts drive different answers. Intelligent interrogation is a recognition that when you work with artificial intelligence, the way you interact is what drives the response, and you need to know how to interact with the technology. And the technology keeps responding and getting better if you give it the right prompts. Give it the wrong prompts, it doesn't get better. When we have artificial intelligence as our coworkers, will have to be trained in how to interact with the technology because it will evolve differently based on our ability to interact with it correctly. On the other side of the equation is something we call rehumanizing time. If I get time back, what do I do with that time? That's an important question. Because if I do nothing, I just became less productive. I wasted time. We often think about small units of time as time that is typically reclaimed by the individual. And for healthcare workers who are often feeling like they're working at 110 or 120%, one could argue that the first 10% is just time back to them. that they have to reclaim just to be efficient at their work. You don't gain productivity until you get a larger increment of time. So you reclaim time, and then you repurpose time. It really depends on what the job is like. But that concept of rehumanizing time is just as critical. Without a plan for it, without people understanding how to use it correctly, all of that is wasted. The net effect of this is that we are fundamentally changing the nature of work. And what it means to do work, and particularly for healthcare, will be materially different half a decade or a decade from now. In fact, I would say a number of people who think very deeply about this in healthcare and who are tracking the technology, particularly generative AI, have a strong belief that within 5 years, the majority of the documentation activities will be done ambiently by technology. I'm not talking about judgment. I'm not talking about recommendations. I'm talking about just documenting what's going on. And that means we can bring the cost of documentation to virtually zero. All of this, though, does not deny the reality, which is we are still going to be a predominantly human-dependent profession. And that's the next challenge, which is we still have to recruit more than our fair share of people from the working population. And we will always have to do that. That will never go away. And we have a problem in healthcare. If you ask the question, why do people work? This is research that we did just before the pandemic. Others have published similar research. What we discover increasingly is that people work for more than pay or professional development. They work for a holistic set of reasons: financial, physical, emotional, relational, employability, purpose. We call this net better off. People go to work for organizations that make them feel net better off. This is true across all sectors. We compete with this every day in healthcare. The challenge we have in healthcare is that if you use this lens, and we have to give people a reason to work in healthcare as opposed to another sector, we're a lagging sector. We did some work coming out of the pandemic. This is US data, so I'm sure it varies by country. But we tested in 7 sectors whether or not employees felt like they were net better off in the sector. Healthcare was the worst performing sector. In the sector that needs employees more than any other because it's the least substitutable. That's a bad place. So we have 2 things going on at the same time. We have the nature of work that's changing, and the meaning of work is changing. And we have to solve both of those at the same time. So all of the efforts that people are placing on recruitment and retention, none of that goes away. It's just not enough. But it does solve a base. So the challenge that we're seeing increasingly, particularly for the healthcare delivery system, is a recognition that the environment and the challenges that we're coming are not the ones that we faced for the last 10 or 20 years. It's a completely different set of challenges. The risk to society, however, is significant because the access problems that we're seeing are unprecedented and will continue to get worse. There is a silver lining. I'm in the silver lining. I'm the youngest of the baby boomers, and all I have to do is live 20 years. Because in 20 years, everyone older than me is gone, and the people who have aged in represent the smallest percentage of the population. So if we can get 20 years from now, we actually solve our access problem. But if you're in the group that's going to need care for the next 20 years, this is tough. But you don't have to be faster than the bear. You just have to be faster than the other guy the bear is chasing. So I hope that as you spend your days, the next 3 days talking about healthcare and technology, that you keep this concept in your frame. Because I know there's a lot of things that we still haven't done like we need to. Sure, we need information. Sure, we need to share information. In fact, those are foundational. Most of the things I described here today have 2 condition precedents, honestly. The first is you're going to have to be on a public cloud, and the second is you're going to have your data in order because none of these technologies work without good data. But none of that's enough. There's other things to happen. But what's more important is not the technologies, it's the problem statement and getting the problem statement right. Because that, if you walk that backwards, it drives all of the other priorities. So hopefully you'll keep that in the back of your mind. Maybe it'll give you something different to think about. I'm happy to take questions. We've got about 15 minutes. And I thank you for welcoming me here. And I'm glad to spend the day with you. Thank you all.
I don't really. Sure. Excellent. Well, thanks very much, Kaveh. And I can see we have some questions coming up electronically, and there's also some microphones around the auditorium as well, if anyone else has any questions. I thought I'd start off with one of my own. And, you know, we all know that trillions of dollars have been invested and are being invested in hospital information systems, EHRs, EMRs, and so on. Do you think we're seeing any benefits from that technology? And could you give any good examples? And, or is it we have to wait for now AI to come along and invest more billions of dollars to get the benefits?
Well, so in the States, I think there's pretty good broad-based research that would support specifically better health care in hospitals because of the use of technology. Unexpected deaths in low-risk patients have measurably improved. And I think there's a very strong relationship between that and electronic health records. The reduction of specific hospital complications, all driven by decision support. I think we have enough evidence to say that we would not be better off if we didn't have it. This is a little bit like the challenge we have is that it comes at a cost. So I think a great analogy here is this is the analog of seatbelts and airbags in automobiles.
Yeah.
A car with them costs more than a car without them. No one would ever drive in one without them, at least not in a rich country. And if you're lucky, it'll never go off in your lifetime. So we have to have that infrastructure there, but it may actually not, the materiality of the benefit won't accrue to everybody, but nobody can afford to take the chance of being the person who doesn't have that.
Great answer, I think. And, you know, I think there are benefits, but I think as you highlighted as well, you know, it's the whole working practice that needs to change. You can't just install a system and expect the benefits to appear. You've got to really reimagine how you deliver services, which perhaps some private sector organization in consumer care have done more effectively. One of the questions coming up was, you know, AI trust with clinicians. Is there a plan to overcome hurdles with patient, general public trust and rapport with AI?
Well, it's a fair question. It's well recognized. So, you know, there's generative AI, and then there's what's called good old-fashioned AI, which is funny that we're even calling it old-fashioned AI. But the truth of the matter is we've known for some time that public use of artificial intelligence in their daily work is going to be related to broadly the rubric of so-called responsible AI, which has concepts like transparency and data veracity and other things. The burden is on us to, if we want to get the benefits to address this issue. I think, for example, to be really specific around generative AI, you're beginning to see this now. We're very strong advocates about this at Accenture. Long before you actually have any examples of generative AI, you need to have governance around it. And the governance will put exactly organizational limits on where it's used. So at the Mayo Clinic, they immediately put some governance policies in place. And one of the requirements, or one of the protocols, is you can't use generative AI to create advice for patients. That's a prohibition. Because people want to try to do that. That's where bad things are going to happen. Accenture as a company has 3 formal policies on generative AI and no generative AI in use today. But we put the policies in place originally right away. And the 3 of them are specifically for GPT. We can't generate any work we give to a client off GPT. We can't generate any code we put into a system off GPT, and no one is allowed to cut and paste any company information and put it into GPT, because this is one of the things people don't understand. If you go out to consumer-grade GPT and you want to tinker, and you take some data that's proprietary, and you put it there, you just made it public. It consumes it and learns from it. So there is a lot around here. The question was around adoption.
Yeah.
And acceptance, but even before that, at the enterprise level, there's a governance issue. And I think if we don't, what's going to happen is a regulatory scheme is going to come up that's going to basically prevent us from doing the innovations we need to do to solve the access problem. So I'm a big advocate for the right kind of governance early.
Yeah, and before I go to the floor, there was a kind of follow-up one around there is about how do you look at the kind of quality control of electronic documentation, and also a hybrid environment perhaps where you have AI bots and real nurses working together?
So great question. And with healthcare data, you have multiple moving parts. Clearly, if you're training an agent, then it's biased by the information that it's trained on. And we know, for example, incomplete data or data that represents current practice patterns that are intrinsically biased. So we've seen this with healthcare treatment patterns that are racially biased. If you use that data in an unfiltered way, you'll just perpetuate it. The machine will be perfectly racist every time, right?
Yeah.
This is a bad answer. We also see this with other kinds of data where we have multiple sources of information that are in conflict with each other. You'll see this with certain kinds of administrative data. And an organization that wants to take its data and then train an artificial intelligence agent to either make a recommendation or take a task over has 7 sources of data, 3 of which are wrong, 4 of which are right. It will be 100% wrong because it'll be a mixture of that continuously. That puts a tremendous burden on getting the underlying data right before you bring any of the technology in. That's the kind of work that people can do today in advance of any kind of technology that they're going to bring for analysis. The good news is that's actually a today problem, is recognizing that is getting some of that right. Some of it will require mathematical models to solve for bias, but some of it, in terms of just getting your basic data accurate, that can be done today.
Do you think organizations like the FDA and other regulatory bodies are kind of aware of this, and are they kind of skilling up to deal with these issues?
So the regulatory bodies, the ones you described, primarily focus on therapeutics. And those are only things for which there's an intended use to diagnose or treat.
Yeah.
That's a subset of what we use in healthcare. A lot of what we do today doesn't raise to that bar and essentially is outside their jurisdiction. So I'm much less worried about things that are diagnostic or therapeutic in nature, and much more worried about things that are not. And what you're seeing now in many countries, the hearings that are going on, are where the regulators are trying to figure out what their posture is, because they're really nervous about generative AI where there's no other regulatory protection.
Sure.
So for sure, it's an area. And I think self-governance is critical, because the absence of self-governance is just going to create the burden completely on governments to regulate.
Yeah. But you could see a day where perhaps AI would write a prescription for a patient without a doctor's intervention.
Let's separate out the judgment from the writing. Because I think the judgment tasks are probably the hardest to get to.
Yeah.
And I'm less, and frankly, most of the things that I showed you are not the judgment tasks.
Yeah.
So I would say that I'm going to spend the next half-decade worrying about non-judgment tasks and advising people not to try to get the judgment tasks right and focus on the non-judgment-based tasks.
And so go to the audience. There's a gentleman in the middle here. If you could give us your name and ask your question. Thank you.
My name's Alan Osford. I'm a recently retired family physician. Can't hear me?
Can't hear.
Is that better if I get closer?
Yeah, that's better.
So, I'm a recently retired family physician, having worked in very automated both clinic and hospital environments. My personal net better feels like about a 10. Now, you talked about that net better off factor, and it was, I think, 5.3 for the medical and 5.8 for the best. So, or what those banking, I think, was the other.
Yeah.
Can you explain that scale a little bit so we understand how big a difference is it between those two?
Yeah. So scales like that have not existed. So we don't have a whole lot of validation to tell you how big of a difference it is. Here's my general thesis, without necessarily getting too quantitative, which is in a sector of society that needs more than its fair share of employees, the last thing I want to be on any scale is at the bottom of that scale. But from a materiality perspective, I don't actually know we don't have enough reference over time. We do know in healthcare that pandemic has had a significant effect on people's willingness to be in healthcare. And I know the research in the States better. I don't know the full cultural milieu here in Canada. But what happened with nurses, for example, was this sense that in the beginning of the pandemic, the lack of PPEs was a reflection of a lack of respect, combined with the fact that so here I am in a job which is inherently dangerous, and then I'm not given protective equipment, and then I'm asked to do more work because there's fewer people, and at some point I just quit because it's not worth it. And so we definitely saw the pandemic accelerated the movement of people out of the workforce by exaggerating the sense of safety and security. So the motivation to be a provider started us in the workforce, but everything else caused us to leave the workforce. I would use that as a qualitative way of thinking about this problem.
Thank you. Thanks.
Great, and we have two more questions on that left.
Hello, my name is Roger Simard. I'm a pharmacist by training and digital health pioneer in this country. Question for you is, they predict that by 2030 there will be a shortage of about 30 million people in the healthcare workforce.
Yeah.
You estimated that we would be able to automate about 20% if we do a really good job and the journey goes well. With the aging of the population, the increase in chronic condition, do you think that we can only work on the back end and not work on the prevention and the patient and education using the digital health innovations?
That's a fair question. So I think the best way to characterize the question is at a macro level, we have a problem with supply and demand. And there are two ways to think about that. You can solve it on the demand side, or you can solve it on the supply side. Now, what I would say to you is we have to do both. Clearly, it's unclear that we would ever be able to solve it on the supply side. But I would also say to you, we spent the last 30 years trying to throw everything we could at the demand side. And I don't know that trying harder is going to give us a big material effect. That's not to say we shouldn't do it, but we do have a body of evidence about the effect we've had on deflecting demand. And even in the United States, you know, we can introduce all kinds of technology around prevention. But there are two things that happen. One of them is it actually increases the total consumption of resources, because one of the things we often forget is that there are people who are undertreated as well as people who are overtreated. We have this mental model that there's just overtreatment, but once we start actually getting everyone the treatment that they need, we end up surfacing a bunch of people into the healthcare system. The second issue is we're converting non-disease disease every day because of innovations that are going on in science. So, you know, cancer, the cardiovascular and oncology programs are fascinating in terms of what's happening, right? And every time we take a disease for which we provide no treatment, it's the cheapest to the healthcare system. Diseases that we can cure are the least expensive, and diseases that we can treat but not cure are the most expensive. So that's actually one of the challenges too, is science is going to drive the process. So supply and demand, for sure, we have to work on both sides. My fear is that the demand side of the equation alone is wholly inadequate.
Thank you.
Excellent. And one more question from the floor.
Good morning. My name's Andre Powell. I'm a health economist, and thank you. I enjoyed your discussion. In terms of thinking about and how a health organization would get started down the path of using AI, what would you suggest as the tentative first steps in terms of working in that direction?
Well, we're seeing a lot of this play itself out. I'm going to work on, there's a technology and a non-technology part of this answer. The non-technology part of this answer we're seeing is a recognition that that when I change work from the way it's done today to the future, where it's a combination of technology and humans working together, that actually doesn't fit the way my organizational operating model and my silos are built. It's actually no one to give the problem to. So we have a lot of organizations that are going back to foundational issues around operating model and who does the work. There's a couple of technology issues, and then there's also the governance issue, which I described. On the technology side, there are two fundamental pillars that are appearing. The first is this is a complete dependency on public cloud. Complete dependency on public cloud. The compute necessary for generative AI will only be done in a public cloud environment. And so organizations, especially healthcare organizations, where the majority of their technology is electronic health records that are not on public estate, they're all in the States, the leaders are all recognizing this, and they're all moving to public cloud because otherwise they're going to be stranded. Second issue is quality of data, which we talked about a little bit. So on the technology side, public cloud and quality of data are the condition precedents. On the non-technology, it's governance and operating model that we're seeing mostly play itself out.
Thank you.
Great, and I think we have time just for one more quick question, which I've got online here, and it's how might we leverage all of the data patients are self-capturing, such as apps, smartwatches, to package it for clinicians for assessment and decision making?
Yeah, that's a fantastic question. It's a complicated question, and I'm going to separate out the scientific validity, which is the thing of research, with making the information accessible. So if we stipulate that information is useful in some form, I'll focus on the fact that the ability to capture it and organize it will be made much more accessible because of the technology. Because today, if somebody shows up with data from their own devices, and it is in a format that can't be used, it's useless. The beauty of things like generative AI is it actually is an answer for things like interoperability, because it can convert things from one language to another. In the consumer space, ChatGPT has learned 50 foreign languages with no explicit training.
Yeah.
So our ability to actually create semantic interoperability is actually quite powerful. So I hope we'll be able to, if there is a use, we'll be able to get it to a useful form with the technology.
Excellent. Well, I think we've come to the end. And,
my pleasure.
Thank you again for taking the time to come here this morning, Kaveh. And great to hear your perspectives. I think we're on the kind of verge of a really exciting era. We've got a lot of the investments in place, and I think it's a matter of making sure that we realize those. But on the other hand, we've also got pressures. If we don't do it, we won't have a decent healthcare system in the first place. Great. And so this kind of concludes this session. Thank you, everybody. Encouraging people to go to the exhibit hall. There's going to be a 30-minute networking break, and please take time to visit the booths where the exhibitor's ready to meet you, and you'll get great information. There's some fun prizes. There's stamps for this leaderboard passport as well. And following the break, then there's going to go into the concurrent sessions, first of which start at 10:30. And so I'll see you all at the trade show. Thank you.
Thank you.
Thanks a lot.